So I'm going to do a video on chest tubes, and so I've got a couple things set up here. So reasons why we might do a chest tube is a pneumothorax, a loculated effusion, or a hemothorax. Those are some of the most common reasons. So a little bit of an anatomy lesson. This is the lung cavity. You should have the lung that's inflated, goes all up against that pleural space, and this is the actual lung here. So pneumothorax, where basically you get a disruption in the pleural space of the lung parenchyma, and air actually gets into this pleural space. So it'll fill and actually create tension and deflate the lung, and it creates more and more pressure here on the lung. So that's what you basically call as a tension pneumothorax. You can have actually pressure on the trachea, you can have pressure on the heart, it can decrease your blood pressure, cause tachycardia, cause hypoxia. That's a reason why we might do a chest tube. Other things are loculated effusions, which basically you can sometimes have fluid in here. It can be bacterial infection, it can be very thick, like an empyema is what we call that. So you can basically have pus, an infection in there, and we might insert a chest tube in there, flush those, and actually put TPA Dornase in there to clean that lung cavity out. Hemothorax, some procedures, trauma, a car accident, breakage of the ribs, or a procedure like a thoracentesis, those types of things can cause blood to accumulate in this cavity, and that would cause basically hemothorax. So just a little bit of an anatomy lesson there. So when we're placing a chest tube, you're inserting the chest tube into the pleural space. If it's because of a pneumothorax, we're hooking up to suction to the pleurovac, and you're basically pulling the air out of this space, creating a negative pressure so that the lung can actually reinflate there. So there are some terms, air leak entitling. So a lot of times I'll ask, does the chest tube have an air leak? And so when you first start place the chest tube in there, if it is because of a pneumothorax, you should have a pretty consistent and steady air leak in the beginning. And the reason is because you have all of this air that's been accumulated in this space, and you hook it up to the pleurovac and you turn the suction on, you should see this air being pulled out, okay? And so where you see the air leak is gonna be in this chamber. There's actually going to be blue water here, and you'll see bubbling. And if you have a lot of bubbling, that means you very likely had quite a bit of air in there, okay? Sometimes you'll have a continuous air leak, and that means you still have an evolving pneumothorax, or still getting air out. Sometimes you may have intermittent or less of an air leak. But any evidence of an air leak tells you that the pneumothorax has not resolved, and it has an increased risk of developing tension. So we have a patient right now that is on a ventilator and on positive pressure. So there's positive pressure that's always being pushed inside the lung. And so he probably has some disruption in the lung tissue that's not closed. And so as long as he's on the ventilator, he's probably gonna have a continuous air leak where the air is coming into his lungs, it's filling his lungs, but it's also going through the actual lung parenchyma into the pleural space, and you're seeing it in your suction chamber or here, so the intermittent air leak. And so anytime patients are on positive pressure, BiPAP, ventilator with PEEP, it's harder to get a resolution or the air leak to go away because you don't have the actual lung tissue basically sealing off. Loculated effusions, you may not see an air leak there, okay? Because it's just this big pocket of pus. We're trying to get fluid out of it. And so these are the hemothorax and the loculated effusion. That's where we're looking at more, how much are we draining out of the chest tube. Somebody's been bleeding in their lung. We've stuck the chest tube in there. We've got 500 out of blood. When over the next 12 hours, we've gotten 300 out. We're trending to see, has the bleeding stopped? Have we got the infection out? Those types of things. So the orders in which we're gonna basically put for the chest tube to be at, there's to suction, which is if you have a pneumothorax, we just put the chest tube in, we automatically are gonna say yes, put it to suction. This piece here is gonna hook up to the chest tube on the outside of the patient, And then there's suction tubing here. This is where it's gonna hook up at the top of here, at the top of the device. There's a little arm. You put the suction there, and you put the other tip of the suction to the regulator on the wall, okay? This is where you're gonna dial the suction. 40, 30, 20, most of the time they put it, the suction to 20. They can turn the suction up to 30 or 40 if they're having increased tension on the pneumothorax. So really important, the regulator on the wall has to be turned all the way up. That's not where you dial the measurement of suction. To know if I'm getting adequate suction here, I have to see the orange box in this chamber. So if you're coming in evaluating your patient with the chest tube, you always should be looking to see if you have an orange box. If you don't have an orange box, then you're not getting adequate suction to here, which means you could have increased risk of tension to your patient. So that should be regular chest tube assessment. I had already said we're gonna have the air leak here, and if the air leak is there, that still means you have an evidence of pneumothorax or an unresolved pneumothorax. To hook your chest tube to water seal, we're gonna see how the patient can tolerate. Are they gonna keep their lung up? Are they in the weaning process? So basically, if the doctor tells you to place the chest tube to water seal, you just take the suction off, okay? It's important that you're assessing your patient once you've made this change, because you no longer have a negative pressure. They could have an increased risk of developing tension. So water seal, and then continuously reassessing your patient. Most of the time, providers do not water seal a chest tube if they still have a consistent air leak, because you need that negative pressure or the negative suction to keep the lung up. And then clamped. Clamped is one of the last things that we'll do in patients. You typically clamp the chest tube for a pneumothorax. We want to clamp it, not have any suction against the chest tube. We want to basically cut it off and see if they can keep their lung up without any intervention. Most of the time they'll have it clamped for at least 24 hours, check a chest x-ray, and then they'll take the chest tube out. We rarely see that in the ICU. So those are the actual orders that you'll have. The difference in air leak and titling, those are the two things that you're gonna see in the actual chest tube. We said the air leak was whenever you have bubbles, and that is an abnormal finding. However, it's something that you would expect to see after putting a chest tube in when they have a pneumothorax, okay? Or if they have an unresolved pneumothorax. So you will see the air leak, and that's just bubbling in this chamber. Titling is basically the natural movement. So you have the lung cavity there, and then you've got the lung here. As it inflates and deflates, you will have a pressure change here with the chest tube, and so you'll actually see titling or movement of fluid inside here. It'll be moving back and forth, back and forth. You'll see it sometimes here moving back and forth. There's no air bubbles, it's just titling of the chest tube because the pressure changes. If you see titling, that tells you that the likelihood of your chest tube being clamped or clogged or kinked or occluded is not very likely. So that's a good thing to see titling. You may not necessarily see titling if you have somebody who has a hemothorax or a loculated effusion. They're going to require frequent flushes of the chest tube, but you would know that it's occluded. So really important with patients who have pneumothorax, increased risk of tension if they're on positive pressure, that you always make sure that your pleurovac is not kinked or occluded. Typically the 14 French chest tubes that get hooked here really easy can get clamped and bent over and occluded. If you're not getting suction to your pleurovac, not seeing the air leak, not seeing the orange thing there, then you could very easily develop a pneumothorax under tension despite having chest tube. So please put your questions in the comments.